And I think that's a good segue to our next topic, which is talking more broadly about Medicare and the system. Australia's been, I guess, a system that is known to be one of the best health systems in the world. And I think a good part of that is this idea of universal healthcare, at least the ability for patients to be able to access healthcare irrespective of their socioeconomic status. Which again, I think we've got some concerns that may well be being eroded. In fact, 6 months ago, we actually had Stephen Duckett, who many of you will know is a fairly prominent health economist, who was on the Strengthening Medicare Task Force. He was on this webinar, and he was unable to say about the results of their work because they hadn't quite released the recommendations yet. But now we are seeing some of the outputs of that task force. Just maybe for the group, I mean, how do we feel about the Strengthening Medicare Task Force program, the quantum of investment that that is being made? Is it going to the right areas or to the right patients? And there was one particular area around voluntary patient enrollment. And Nick, maybe you might want to comment about that. But more broadly, like how do we feel about this program? Is it going to do what it's supposed to do?
I mean, I think the unanswered question there, Marcus, is nobody's actually decided what it is it's supposed to do. And by which I mean, Minister Butler was asked this question, and it could have been Minister Hunt or any health minister in the past 20 years. But he was asked a question at a press conference about 6 months ago. Does Australia, actually it was at the conference where he released the Medicare Task Force report, does Australia actually have a universal healthcare system? And his response to that was yes, because anyone with an emergency can go and get free healthcare and be admitted to hospital. Now, if that's our definition of a universal healthcare system, I think that's likely to be wildly different between Minister Butler and the rest of the country, maybe. But regardless of what the definition is, we can't create a system unless we know what we want to achieve. So do we, and I saw, thank you to Chris Dens for his ongoing contributions in the Q&A, but Chris's first question was, what's the problem with paying for a GP when it's the same as filling up a tank of fuel? Well, good question. Previous health ministers, I think it was potentially Minister Abbott when he was health minister, floated the idea of a $5 co-payment. Now, a $5 co-payment looks like peanuts when it's now got an extra zero on the end and we're paying $50. So I think I don't think we're going to get back to a system where primary care is free for the majority of Australians. We're a couple of decades past that. So then the question is, what is a reasonable amount for Australians to pay for primary care? That is to see a general practitioner or another primary caregiver. And can we look at the people who are falling through the gaps with enough granularity to do as what Stephen suggested and bring in other ways beyond just a sort of big bulk billing incentive to really target those patients? And I've probably said enough with this answer. We can get onto the different funding mechanisms apart from fee for service, which is one of the ways you can achieve that.
I'll add something else. So Stephen Duckett's on the Health Direct board now. He's one of our independent directors, and so he brings some of this thinking into our planning. What I'd say about the voluntary registration, I'll comment just on that part, is it supports our idea that that there's no one solution. There's no, for a guy in their 20s, there may not be value in having the same GP practice they go to, all the time. But there might be for a parent with young children who have some complications. So it's kind of horses for courses. And I think the report reflects that, in that it doesn't say this is for everybody in the way that it is in the NHS, as I understand, with the registration there. But it's trying to identify, well, who would benefit most from having a regular GP for continuity of care. And some of the work we did during COVID with a few states, New South Wales, Queensland, South Australia, was they helped identify patients who had COVID and were at higher risk of severe disease. They passed through the data on those patients with their regular GP, because there were surveys that kind of got this from the consumers with their consent. And we then connected them with their regular GP with information that they might be eligible for antivirals, assisted with the booking. So it meant that for that cohort, there's a specific cohort where there was an immediate benefit for them to get a fast track access to their GP for the purpose of an e-prescription. And we found that about 30% of that cohort didn't nominate a regular GP. And these are people who had either underlying chronic conditions or who were older. So to be eligible for the antivirals, you had to kind of be in that cohort. So I guess that was a surprise to us. And I think that's what the Strengthening Medicare Task Force report looked at, is there's probably a whole bunch of Australians out there who don't have a regular GP and who would benefit from that personally, and the health system would benefit from the management of their care in a more coordinated way. So I think that makes sense to me. But that's just about that cohort. So I think there's a lot of other problems to solve that the report didn't try to solve, and I can't do everything at once. But I think for that part, it made sense to us.